Okay, Jammer.
Yeah, እንጀምር ዶክተር ወንድሰን።
Yeah, very good. So, are we going to discuss in Amharic or in English?
The audiences are partly professionals and partly non-healthcare professionals. So I think we can mix the language.
እሺ እንግዲህ ቶሎ ቶሎ አቅርቤ ቶሎ ሄድና ቶሎ ከጨረስኩኝ ስብሰባዬን እመጣለኝ። ይቅርታ እንደምታውቁት ብዙ ግርግር ስለሆነ ነው። እንግዲህ ሶስተኛ ወሩ ነው። It's a very amazing disease. ምክንያቱም it all started at the end of December. ዲሴምበር መጨረሻ ላይ ነው የጀመረው። አሁን ሶስተኛ ወሩ ነው። nearly ወደ 800,000 ሊጠጋ እኮ ነው። አሁን ቁጥሩ እየጨመረ ነው እና በዚህ ሬት እንደዚህ ፕሮግሬስ ያደረገ ኢንፌክሽን የለም። It's due to a viral disease. ኮሮና ቫይረስስ ናቸው። የመጀመሪያው ቫይረስ እንግዲህ the last 2 decades this is a third virus which has transcended from animals to humans. የመጀመሪያው ሳርስ ነው፣ የሚቀጥለው መርስ ነው። ይሄ እንግዲህ ኮቪድ-19 ነው። ኮቪድ-19 በሳርስ ኮቪ2 አማካኝነት ነው የሚመጣው። የመጀመሪያው ቫይረስ አሁን እና ወደ አሜሪካ አካባቢ ሲታይ እስካሁን 8 ሰብ ታይፕ ደርሷል። ያ ማለት ቤዚካሊ የባክግራውንድ ጂኑ ሆሞጂኒቲውን የጠበቀ ቢሆን ቬሪዬሽንስ እያመጣ ነው። እዚያ ምን ማለት ነው? በጣም ፋስት ኢቮልቭ የሚያደርግ ሃይሊ ትራንስሚሲብል ነው obviously by the number of cases that we do see, but the good thing about it is still mortality ብናይ እስከዛሬው ድረስ ያለው ፊገር it's about 4% ነው ኬስ ፋታሊቲ ሬት። አንዱ እንግዲህ ስንት ሰው ይገላል የሚለውን ነገር በደንብ አላወቅነውም፣ ምክንያቱም ዲኖሚኔተሩን በደንብ አናውቅም። The number of people who die actually registered ናቸው፣ ግን the number of people who are infected we don't know clearly because majority are asymptomatic. That's something about the disease. እና ሌላው the point which I want to raise is the most common symptoms are fever and cough. So if a patient has fever, cough, and if you add shortness of breath to that, and a history of contact ካለው or history of travel, it makes it very likely ማለት ነው። እና the diagnosis confirm እናደርገው በRT-PCR ነው። So now we have problems with the test because the test is being done at one site alone. Now this is one of the limitations that we do have. Testun we have to build up our test capacity. እንግዲህ as I have already said, the most important symptoms are fever, cough, and shortness of breath. ግን the Chinese cohort, the most frequent symptom still fever, cough, and then myalgia, arthralgia ነው። Headache, shortness of breath, and comes last is diarrhea. Few had diarrhea. And interestingly enough, only 40% had fever at the time of admission, but as the disease progressed, nearly 80% had fever. ስለዚህ no fever cannot exclude that someone is infected. And this is one of the problems, again, that makes a diagnosis not easy for us. Okay, so the most important ones in managing these cases are one, we have to confirm the diagnosis, and that is a lab, the confirmation. And then the cases should be quarantined, the contacts should be traced, and at public health level we should do the social distancing. So these are the most important points in relation to the disease symptoms. And when we do imaging, initially patients could have normal chest x-ray, normal CT scan, but as the disease advances, many and more number of patients would have bilateral ground glass opacity. They would be hypoxemic. And for us, lymphopenia is a very good indicator. So lymphopenia, if the absolute lymphocyte count is less than 1,000, so in our case, I had a chance to see a couple of cases with similar problem. And in our case, if a patient presents with fever, cough, shortness of breath, and if a chest X-ray suggests bilateral pneumonia, and if there is no leukocytosis, and in fact, if there is lymphopenia, so we need to suspect now at this point in time COVID-19 as one of our differential diagnoses. So in order to confirm, we have to send sample to the lab. But even if the process is not easy, the test is RT-PCR, and the sensitivity is 60%. So now we have to realize that a negative test doesn't rule out the possibility of COVID-19 because the sensitivity is only 60%. So we haven't yet analyzed the sensitivity of the tests done here in Ethiopia. However, but from studies published at New England Journal of Medicine, it's below 70%. So we need to have high index of suspicion, and in a case that who fits with a criteria, with a clinical picture at present, because the disease is already in our setting. So we need to suspect COVID-19. We have to isolate patients, and if we couldn't confirm the diagnosis, at least the case should be isolated and the maximum precaution should be taken. One of the peculiarities about this disease is nosocomial transmission. So this is one of the problems with coronaviruses in general, particularly when it becomes an epidemic or manifests as an outbreak. Sorry, hello, Abid, መጣሁ። እሺ Okay, so they are calling me, so I will join you back. So these are my points, and after 15 minutes I will try to finish a brief meeting and come and I will join you. Sorry,
Okay. Thank
I
you
have to
very
leave
much.
now.
Thank you, Dr. Anderson.
Okay, bye.
Okay. Dr. Anderson has presented a brief discussion on COVID-19. Maybe the points I would add is regarding the test we are using. RT-PCR we are using. Actually, I was also faced this question. My suggestion is it varies on the site we take. If we take nasopharyngeal, it could be like well over 60%. But if we take throat swab, it's like 30%. The highest yield would be for that of the bronchial yield. So the AGP procedure, aerosol genetic procedures are associated with high risk of transmission, but that is the highest yield. I don't see any. I don't see any question coming from the audiences. But if there are questions, in the meantime, we'll discuss. But otherwise, I just want to talk on the prevention of this virus. Like it said, it is related with the droplets and usually it's transmitted by contact. So it's promoted to have proper hand hygiene as well as proper capitic, and it's very important that we have social distancing of 1 meter. And this virus is also shares through fecal route. Like 100% of patients do have fecal shedding. So it's very important that we have hand hygiene as well as capitic, and we don't have to touch our faces, mouth, nose, and eye related to it. But I don't know which audiences are there. Barakat, can you tell me how many audiences are there, and then I will discuss about maybe the prevention and the treatment, the new developments regarding that, and how our setting should go. Okay. So regarding the prevention of this disease, it's very important we have to prevent. But it's like 80% of them are asymptomatic, or they do have mild disease. But the worry is that for the 5% of patients that are going to be critical, I mean, those are the patients who need ICU admission and they require ventilators. The amount of ventilator we have and the amount of patients that are going to be affected, we have to know beforehand. So, according to the epidemiologist's report, like 40 to 70% of the world population will be affected. This there will be so it will take like 50-60% on average for Ethiopia, like 3 million of the critical if the condition diagnosis. So the amount of ventilators we have, if we take in total, is not that much. If you take the maximum number, it's around 300. So if you take the ratio, like for everyone, then 10,000 people who require ventilator, we are going to treat only one patient. So this is a dire situation. What we have to work more on prevention. We have to do maximum work on the prevention. So that's a very important thing. So it's a very difficult condition if that condition has come into attention. So the most important thing is still the prevention. If you have questions or suggestions, you can send me for the chat list. But I don't see any one of you doing that. I'm waiting for you, so you can do that. And maybe the other important topic to discuss on is the treatment. So there are different trials, more than 44 trials going on for vaccine, and lots of trials going on for the development of drug. But the remdesivir is has now passed the human trial, but there are the reports that hydroxychloroquine are effective studied in France, but the sample size and the methods are not that much rigorous. So, I mean, the American College of Cardiology particularly suggests to undergo proper clinical trial before really recommending, because there is this disease associated, this chloroquine and oxychloroquine associated with ventricular arrhythmia, particularly low QT syndrome associated arrhythmias like Forsesky pointers. So you should be cautious, and you have to follow the evidences that are evolving. But I think we have to get proper study before just embarking on treating on chloroquine plus azithromycin. Let us follow the unfolding discoveries. This is what I could say. But if you have any question, I'm waiting for that. Okay, now, there are many figures regarding the COVID. Okay. 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 Now, am I visible more? Yeah. So there is one question I'm reading here. There are many figures regarding the COVID. My question is, how sensitive is negative tests in severely immunocompromised patients? And regarding English level, it's actually more sensitive. Yeah, like I said, yeah, it's more, this Sputum is more yielding compared to the others. Otherwise, I didn't come across specific figures that says uh, sensitivity of this test, particularly in immunocompromised patients. So, like Dr. Anderson was saying, and like I was saying last week, any patient who is fever, cough, so fever is present in around 80%, cough will be in around 80%, plus shortness of breath and leukocytosis or leukopenia, particularly of lymphopenia, with bilateral chest infiltrates is highly suggestive of the COVID-19 infection. Some centers say even if the RT-PCR is negative in such particular patients, we have to repeat and see again and again until an alternative diagnosis is uh, produced. Maybe if there are physicians out there, another point of discussion is regarding providers that we have just few ventilators in the country. Proper guidelines to treat home to treat if the channel would arise. I mean, this is also a more important issue to discuss based on what we have. So I think that we have to see we have to have guideline because Italy has developed such a guideline to treat such patients. Any other question? The other point we need to see as physicians and as care workers is that the virus spreads exponentially. I mean, the trend is like every other day, every Saturday, it will double. So we expect it to double. But the Ethiopian trend is not going like that. I don't know why it's like that, but if we escalate our testing strategy, if we start to test also suspects, I think we might have room more, but globally it has this exponential pattern. Any question you can put in your chat box, then I will read and I will try to answer. Maybe the other point we need to discuss is the type of mask we are using for prevention of this virus. Regarding any virus, including this virus, there is a study that says N95 mask and there's a surgical mask. You have like 95% protection from this virus. The issue is surgical mask is disposable, so you don't have to use it for a long time. And the other thing is the N95 mask if you are using continuously, finally for the account, the program will use the strong problem. And I've seen some suggestion even on the media that says you can wash and reuse it. I don't think that is scientifically suggested. You have to, if you are going to wash it, you are going to, enlarge the pores and destroy it, and it's not recommended. And the other thing is, the cloth masks now they are developing. Cloth masks have 0% protection regarding viruses. So maybe if you are using them to protect, not to touch your face like that, it will be fine, but it's not that protective one that you use in healthcare settings. So I see lots of people producing locally settings in the healthcare, but the evidence regarding that is not that much. So we have to strive to have proper PPE and 95 as well as surgical masks, the problem. So when we have to use masks, we have to Google to get that. It's not going to be okay, we just use masks only. And if you are going, if somebody is assigning trial area, it's better to use mask, surgical N95, the Google, as well as lab. This will be enough for just screening of patients. If somebody is going to treat suspects or confirmed cases, the full armor of PPE should be used, and, including the whole body protection, the whole gown, proper gown, as well as boots, and plus the previous things are said. So it's very important that we use PP. We don't have to compromise PP because if one health professional is infected with this virus, the chance of transmission to other co-workers and other patients will be very high. So infection of health professionals shouldn't be seen simple thing. So we have to try to get as much PPE as possible in healthcare settings. And I would suggest not to spread some unproven things like clothes, masks, clothes, something like that. So it's better to use standard things regarding the prevention of the coronavirus. So we have to try to use that. Is there any question again? I can't see any question here. So we'll wait for just a few minutes for Dr. David. If he is going to join us, I don't see him. Uh, is there any question? Maybe the point I want to raise is also the other issue is total lockdown and the subsequent things is going to come. Since yesterday, there is lockdown in different regions. So when we see, I think what's happening is we have to also see the other people with chronic illness, like those people on dialysis, those people who are having chronic illness and on follow-up. So if we completely shut down transportation, it will endanger the life of these people. So we have to think such this as well. And the other thing is we have to also think about the vulnerable population. Uh, so I think we have to act reasonably, considering what's going to come. And the most important thing would be social distancing as well as proper hand hygiene and the proper use of mask. That's what I would suggest. If somebody is having cough, he has to wear mask, and if he has to cough, he has to cough on his on tissue or on elbow, left elbow. That would be fine. Proper cathetic practice should be in place. Uh, that's what I would suggest.
Diciamo, io che opterei di entusiasmo.
Is there any point you want to discuss? I see you here. I see you here. Okay. Gene expert and other modalities versus COVID test are being suggested. What's your opinion? Okay. Okay. Okay, now I can get it. Okay. Gene expert and other modalities versus COVID test are being suggested. What's your opinion? The test done in Ethiopia is RT-PCR. What we do is RT-PCR. But regarding sample collection, uh, there are different reports, but I didn't see it personally. But people who have been there, I've seen lots of people, they take throat swab. So uh, if they are taking if they are taking nasopharyngeal swab, I'm not sure. Okay. Okay, now I can get it. Okay. Anyways, with throat swab, the yield will be around 30%. With nasopharyngeal, it will be around 50%. So it depends on where they take. Gene expert, I didn't come across this. Maybe when Dr. Anderson comes back, he will talk about this thing. But what I know is RT-PCR is what. Uh, difficult now. Am I audible now? Any more questions? So if you are not having more questions, just let me discuss for a few minutes. The most important thing is at this particular time is I think it has started, the community transmission has started. So we have to have high index of suspicion. Like Dr. Anderson was saying, symptoms might not come at the same time. For example, fever might not be coming early, cough might not be coming early. So we have to have high index of suspicion. So contact tracing is important, and then we have to follow patients properly. Any patient with respiratory illness, we have to doubt, and we have to properly work up. And in the facility where we work, we should have we need to have pre-triage rooms as well. And we have to where the place where I work now, we have set up this pre-triage center. So we will check those people who are for fever, for cough, shortness of breath. If these patients are having such things, we will isolate them and then we will go accordingly. And other patients who are not fulfilling this criteria, they will be seen in the standard OPDs. But that doesn't mean they don't they don't that doesn't mean they don't have the disease. So we have to properly use PPE and we have to follow them properly. And the way I think is that every patient that comes to you, you have to properly use PPE and you have to suspect. And you have to go about that. Because this patient can be asymptomatic as much as 60% of the patients. So you have to suspect that. Oh. So, Abbott company has now developed a test kit which detects the virus in 5 minutes. It's a very nice development up until now because current tests take up to 72 hours, what we use here. So not less than 24 hours. So 5 minutes test will be bedside test. That will be fine. With that, we will big loss of patients who are having possible disease. So, any more question? Any more? So now, next week we are going to have live webinar this week Thursday at 3 p.m. Dr. Seifa Johannes from Washington Hospital, Central DC, critical care specialist. He will be with us, and Dr. Henok Seifa, assistant professor of surgery from Blackline Hospital. They are going to be our guests next time. So they will present on particular topics. If you have topics and points of discussion regarding critical care and also related to surgical issues, you can raise at that time. And also please invite as much possible, invite lots of audiences so we can raise lots of issues and we will be more on the same page when we discuss about this disease. And this is a platform that we want to make it more routine so that everybody can be involved and can have proper flow of information. As you can see, lots of informations are passing to the community. If we health professionals do have proper understanding about the disease and a proper agreement among ourselves, we will save the public from fake information and unnecessary panic. So the topic is don't panic, act rationally. So thank you very much. Uh, I think I've been here. See you next time, next Thursday at 3 p.m. Bye.